Dear all, thank you for inviting me for this conference and thank you for joining me for this presentation. My name is Arianne Verhagen and I am Dutch physiotherapist and clinical epidemiologist. And at the moment I am working as the head of the discipline of physiotherapy at UTS in Sydney. I am asked to present a paper that I published in 2019. The title of my presentation is No New Trials on Exercise Are Needed in Knee OA. And in the next 25 minutes, I will tell you all about the why and the how and how we did it. So let me first introduce my team. During the bulk of my research, I was part of a team at the Erasmus Medical Center University. Along with some of the highly esteemed kind of osteoarthritis kind of researchers like Marienke van Middelkoop, Sita Bierma, and Jos Runhaar. Two of the team members are part of the National Health Institute, which I'll explain later. And for the second aim of this presentation, I asked Manuela Ferreira from the Sydney University to join me and help me with the fancy analysis and the difficult things. So just on a side note, this team is, apart from one man, only females, and I think we did a wonderful job. So Jos Runhaar is the only male in the team. So let me first start with a bit of the background on the why of this study. In the picture you see in some of the slides, you see these kind of nice fancy pictures. They're from the new library of UTS and everyone is very proud on that building. It is an award-winning building and it just opened just before the pandemic. So we're now starting to use it and that's fantastic. So in the Netherlands, the Minister of Health requested advice from the National Healthcare Institute to evaluate whether exercise was effective in patients with hip and knee osteoarthritis. With effective, the minister liked to see an effect that was clinically meaningful. And if effective, it would mean that treatment of people with hip and knee OA would get part of the reimbursed physiotherapy sessions as some other conditions are. At that moment, it was not reimbursable under the healthcare scheme, so that would be, in our view, beneficial. Nevertheless, several Cochrane reviews already existed, and they all showed that exercise was effective, especially compared to no or minimal interventions. And that was the question of the minister. We want to know how effective exercise are compared to doing nothing or use your care. This means we had to answer the minister, we had to update it to the Dutch situation. And that means that we had to update the reviews of the Cochrane and be a bit more selective in the study selection. So we're not able to see Tai Chi or home exercises as exercises because the minister definitely wanted physiotherapists to do the exercises. But also the control interventions, they did not accept ultrasound or ineffective treatments anyway. So we had to be a bit more selective. So what are our study aims? These were our aims as presented here. First, of course, the main aim was answering the main question of the minister. But as a research team thought, is that how many trials do we need to do on these kind of research questions before everyone accepts it's effective? Because in our team, we already thought this is an effective intervention. So why bother? Why bother doing another systematic review? That's also the reason we never published a systematic review, because we couldn't get us doing that. And some of us already were finally concluded that a study on this aim was redundant and should not be funded anymore. And that's why we added a second aim. Can we calculate how much data we need before we can change the effect estimate to something that's not clinically worthwhile? And assuming that we would find a clinically worthwhile effect size, of course. The next slides, I like to explain how we did and how we tried to answer the study aims. But I also assume that most of you are a bit familiar with the basics of a systematic review. So I'm not going to deal with that in depth. I'm just going to explain you the basic things And I will focus in this presentation on the extra analysis for the second aim, because that is the fancy analysis, and that is the analysis I would like more people would like do these kind of analysis to help the research community not conducting redundant studies in this field. Yeah. So we did a systematic review according to the Cochrane methodology at that time, and this was in 2016. So you have a bit of an area where you can see what normally used to be done in these systematic reviews. We used the data that was already collected in the Cochrane reviews, including the risk of bias assessments, and we did and next to that we did a transparent and reproducible and whatever kind of search, and we ended up with over 9,000 hits. We assessed the risk of bias using the Cochrane neck and back review group kind of tool. At that time, there was no risk of bias 1 or 2 yet available at the Cochrane, so every research group, a review group, had their own tools, and as musculoskeletal researchers, we were very familiar with this one, so we used this one. And for one reason or the other, the existing Cochrane reviews also used this tool, so that was easy. The outcomes of interest were the minister would like to have response to treatment as the main outcome, but we already thought that's not going to work. So we also mentioned in our study protocol that we would assess pain and function. And the minister would like to have long-term outcome. And we thought, whoa, we're not sure whether that's doable. So we said we do it immediately post-treatment, 3 months after treatment, 6 months after treatment, and 12 months after treatment. And this is how they wanted to see it, what happens after treatment, not after randomization, because the minister is not a researcher. So it was after the intervention. These are all kind of different things you need to know before you can interpret the outcomes. I must say in this presentation, I focus on the outcomes of pain immediately post-treatment, because this is the bulk of the studies and that makes it fancy to analyze. So first, the analysis consisted of 5 steps. The first step was that we did an ordinary, normal kind of analysis for a systematic review. So we did a meta-analysis using a random effects model, and we used grade to grade the evidence. And next, or grade the certainty of the evidence or the quality. And next, we evaluated possible publication bias, because we thought that might be interesting to see if nothing is over there forgotten. And our analysis, this analysis on publication bias was just eyeballing, because we don't feel that the analysis given for publication bias is very valid and robust. And you can see by eyeballing, you can see a lot. For the second aim, we did a step-by-step evaluation of the robustness of the findings we found. And at the end, we calculated how big a new trial, or how big the effect estimate of that new trial should be, to change the pooled estimate to something different than we found in the basic analysis. So publication bias, as I said, we also did a bit of heterogeneity. So we looked at subgroups. We have looked at every subgroup you can imagine. So we had a priori an immense list of subgroups we thought would be relevant. I'm not going to present everything to you, but I do present a couple of them. We did a cumulative estimate, meta-analysis, to see how the pooled estimate will fluctuate over time. So how robust is the effect estimate over time? And this is the last one. We did an extended funnel plot to see what the impact is of new data when we add it. Please join me in hearing the results on these 5 steps. This is a bit, it's turned around. This is the lower bit of the funnel plot, the forest plot we made about pain. This is the responders. Yeah, the responders, we had just 8 studies looked at responders. And that was the minister's primary outcome measure. And well, as stated before, this is a dichotomous outcome measure, you responded or not. The problem a little bit was that every study defined that differently, and some studies did not even provide data for us to calculate. So we ended up in 8 studies doing this. And the official analysis has 52 studies, so it's just a minority of people that looks at responders. And what you can see here is that the pooled effect estimate is 28% increase in number of respondents when doing exercise compared to nothing. And what you see over time is that it reduces to 5 to 6% and starts being significant, statistically significant. This is the top of the funnel plot of the forest plot on pain, and it includes 51 studies because one of the studies did not mention any pain outcomes. And what you see, it's a huge table. It's really, really huge. And this is just the upper half to give you an impression how a full-blown forest plot looks like with a lot of studies. I don't see that quite often. And this one is the bottom part. And what you can see on top, oh, my picture is in front of it. I'll move that. I'll move that a bit. What you can see on top is that we have a 0.5 standardized mean difference in the immediately after treatment estimate, and that reduces a little bit to 0.22 or 0.27, and it stays all the way statistically significant. The clinical meaningful effect we a priori set at 0.38, and that was based on previous studies. So, and the minister was happy with that one. I'm not sure why. So only the post intervention diamond showed a clinically meaningful and statistically significant effect. The rest was statistically significant, but not clinically meaningful, as according to our a priori set cutoff. So what about publication bias? We were able to include 42 studies. I'm not sure why, because that was on pain also. Oh no, that's just post-treatment people. This is 24 people, 24 studies included studies that had an outcome just immediately after the treatment. So what you see on this picture is that on the x-axis, you see the effect size on standardized mean differences, and this is the pooled effect size when we pool everything, like I showed you on the previous slide. Oh. On the vertical axis, you see a kind of measure for the size of the studies. This is a lower size, so a smaller size of studies, and this is the bigger size of studies. Normally, a funnel plot should have kind of this kind of shape, like a real kind of funnel, and this one is remotely looking like a funnel. And normally the bigger studies have a more precise estimate, and then it goes down to there with a more variable estimate in the smaller studies. What this plot shows you two things. First, that all studies were more or less the same size, because it all bulks here together. And second, left and right from the vertical line, you have about more or less the same number of studies. And the idea is that on the left side here, you should have less studies, because publication bias means that you do not publish then the small and negative findings, small studies with negative findings. And we clearly do not have the idea. We see that here or here. Oh, it's the other way around. It should be here, the empty spot. But normally one of the spots should be having an empty part of the lower part of the funnel. That is the publication bias. So we concluded from this slide that we don't have apparent publication bias. Looking at heterogeneity, as I said, we have an enormous amount of subgroups evaluated, and the main ones I'm going to show you is first how osteoarthritis was defined. And you had a couple of studies that they only had clinical criteria for inclusion of patients, and another bulk of studies had radiographic selection criteria to include people in the trial. And that's a subgroup we evaluated. We also looked at the duration of the intervention, and we took a cutoff point of 12 weeks. That was actually a kind of convenient cutoff point. We did not a priori mention that, but we wanted to have a bit of equal groups, and this makes sense because in the Netherlands, osteoarthritis treatment, its duration is normally about 12 weeks. And then we did look at whether you give exercises in a group or individually. We also looked at exercises in water or on land. The hypothesis is that if you are doing exercises in water, you don't have the body weight compressing the painful joints. So the idea was that could be more beneficial. And the last one is that we also looked at a risk of bias. So we pulled only the low risk of bias studies compared to every study, or the high risk of bias studies. And the ones in blue did not show differences, and the ones in red were showed differences, and these differences markedly. So the in group exercise, it doesn't even reach our clinically worthwhile defined effect size, while in the individual group it is rather big. And also the studies with low risk of bias had a little bit of a higher effect size compared to everything. But that was not a big difference. The only remarkable difference was this one. Good. This is a cumulative meta-analysis. I have difficulties with the word, so stay with me. The plot represents the cumulation of studies over the years. So on the y-axis, you can see the different years. The first study started in 1992, and every time we added a couple of studies and we entered the next year, we added these studies to the pooled effect estimate. So these are all pooled effect estimates except the first one. And the horizontals are the 95% confidence interval of the pooled effect estimate. So over time, it started in 1992. We had the first study, and we ended in 2016, where when we did this final analysis. And this plot shows you three things. First, none of the 95% confidence interval crosses the line of no effect, and that's here. So actually every pooled effect size was statistically significant. Second, from the beginning, almost all pooled effect sizes showed a clinically relevant effect. Maybe not this one, but the rest is probably eyeballing about almost near 40. So a couple of these early ones maybe not reach the clinically meaningful effect size, but definitely the later ones do. And third, the effect estimate starts to be stable from 2010. So our conclusion was A, it is effective, statistically significant. B, it is clinically meaningful, effective most of the time when we have enough studies in it. And C, the effect estimate is robust over time. So we can say that this is the effect size around 0.5 that probably will be representing the real effect. So we also boldly try to say that all studies after 2010 were redundant. And the last thing is the extended funnel plot. This is a different plot, and bear with me, I'm going through it. It is rather colorful. And what you see here is the same plots as we had with the publication bias. So the same studies were in the plot. This is the line of our clinically worthwhile effect. This is the dotted line is the line of our pooled effect size. And the red area here presents any new study that has a dot in this red area that will represent here in this red area will contribute to the meaningfulness of the effect size. Even make it bigger when it is more to the left, make the effect size bigger, but still clinically meaningful. And because of the bulk of studies, smaller studies that might not be effective still do not change the effect size. The green area is any new study that is in the green area might change the overall effect size to clinically not worthwhile. So on the other end of this straight line. What you see here is that a study should not only be very big, bigger than most of the ones we had, but also have a huge negative effect size or a huge positive effect size. But the smaller ones need to have a huge negative effect size. An effect size we don't see because these are the two ones that are most negative. So we, based on this thing, showed that we think that no new trials can change it to unclear whether it's clinically worthwhile. You also see here a blue area. normally these plots also have a kind of blue area where it changes to not clinically worthwhile. So we can't think about any study big enough or have a big enough effect size that changes the effect size to clinically not worthwhile. So this is why we, therefore we think that no study can change these effect size to anything remotely like unclear or not clinically worthwhile. Good, and this is a bit of a larger discussion because sometimes things seem to be very easy, but we went on from the easy thing and thinking, what does it mean and why? So how did we go from here? Well, first we had a conclusion. This is the title of the, come on. I have a bit of a problem with the slides. Yep. So this is the title of the publication. And in that publication, we conclude that exercise is effective and clinically worthwhile when compared to no or minimal interventions, and that adding new data doesn't change the conclusion. But that is the simple and the effective, this is a simple answer. But we went on because the answer to our second aim is also clear. We do not need any new data, but how do we make sure that people understand this message? Because this message has been given before. Manuel and I were part of a study looking at exercise treatments compared to no or minimal treatment in low back pain. And we concluded that was not effective. And this was the first time we trialed this fancy analysis that Manuel is very good in doing. And we published that paper in the BMJ in 2012. And we were thinking, nobody took that message. What happens? Why isn't it? We had a feeling nobody took that message. So how do we make sure that the uptake of the message is going to be in a way that it helps, that we actually help the research community? So this was a study we published in the BMJ. And then we thought we have to investigate whether this study had any effect in less new protocols and less new studies. But one paper is just a case. So we thought, is there any other message in any other remotely similar area? And we found a Cochrane review on the management of chronic pain that actually gave the same message. Was also published in 2012 when we found it. I think it's now updated. But also that study in 2012 mentioned that CBT was effective in the management of chronic pain and should be delivered. So we then went on with another study, and that other study had the aim: do the number of protocols reduce or change, differ after the publication compared with before the publication? So do people take up the message of we don't need another low back pain trial or another CBT trial from when it's published? So we thought about how to do that, and the only way to do it is to look at published protocols. So we analyzed a number of trials registered in the WHO before and after the recommendation, and we took a certain time window way before, not very way before, but shortly before the recommendation, but another time window a bit longer after the recommendation, because we need people to give people the time to understand the message and change their behavior. So we calculated the number of protocols on both specific research questions and in the WHO register, because that is the largest trial register we're aware of. And a priori, we defined that a time frame before and after the publication would be slightly adjusted halfway, because the number of CBT trials was 10 times different than from the low back pain trials. And we also a priori defined what we call a change. And we said it should at least have a difference of 20% to call it a real change. So then we thought, well, we're not looking at the numbers per se, but also if there is a difference between the uptake of CBT or exercise in low back pain, we might have a look at what kind of factors these publications differ. And I'll show you the table, because remarkably, we found over 20% increase in low back pain protocols, addressing the same question as we did the recommendation on, but also an almost comparable reduction of the ones in CBT. So this is the increase, the relative change of protocols, because you can see there's way more registered after the late in the 2016, 2017 than before. So we did a relative change, and we found about 33% increase of protocols compared to a 32% decrease of the protocols on CBT. So the funny thing is, what constituted to this difference? We had a good look at it, and we finally came to the conclusion, this is, by the way, the publication. We finally came to the conclusion that the publication should be visible. There is a way of dealing with it. It's the recommendation should be strong, and media exposure makes a difference. The visibility of our low back pain trial was 0, because whatever we tried and whatever search strings we tried and whatever we did, we could not find, based on low back pain protocols, trials, new trials, adding data, whatever, to find our low back pain thing. Publication. Although it was published in the BMJ, we were not very looking very good. We were so focused on explaining to the research community how fancy the analysis was that we developed, that we didn't think about the visibility of the message we actually gave underneath. So also our Cochrane review by itself is visible, and the recommendation in the Cochrane review was in the abstract. So if you do whatever you do, you find that one. So the strength of the recommendation was also different. We were very, very, very cautious in saying, well, better not to do any new trials, while the Cochrane review was blunt. Don't do any new trials, not necessary. And there was a difference in media exposure. First, we thought, well, the impact factor of the BMJ is way bigger than that of the Cochrane, which is, at least at that time, but their media exposure was way, way bigger than ours. Let's see if I have some data. Yeah. The media exposure of our low back pain paper, we had an altmetric score of 21 based on 30 citations. The same moment, the Cochrane review had an altmetric score of 110. And 586 citations. So that's a way different way of citing things. So how did we do with this paper? So far, I just looked at it yesterday. We have 22 citations, 85 captures. I'm not sure what it means, because this journal, the Osteoarthritis and Cartilage, doesn't give me an altmetric score, but they do give me these data. So it has 22 citations. And 232 social media posts. Unfortunately, some of these tweets were related to a person, a man, with the same last name as me, but not in this area. So it is sometimes very difficult to find yourself back. We didn't think, when we published this paper, we didn't think about it, but this is something we learned. But what we did nice was we did put the outcome very bluntly in the title. So that's all good. But I think we might do a little bit better on the social media thing. And that's something I learned now. So my take-home message from this presentation is just publishing your research is definitely not enough. We all know that, but we all forget to make it better. And we all are so worried with the next publication or the next grant application you need to write or the next student that comes along that we don't think a lot about that. So a publication is kind of selling your story and your message. So my recommendation would be put firm, if you have nice conclusions on the study, and always have a look at whether you can come to a clear, clinically worthwhile, nice conclusion, put it in the title. My feeling of being an editor on the systematic reviews portfolio of one of the journals, I feel some people just stop after the analysis, and then they have a kind of conclusion like it's unclear and we need more and things like that. These are conclusions that are no longer viable. There is always some juice in the results that you can highlight. So I would really recommend to think about a clinically worthwhile conclusion and highlight that in the title. And it would be nice to tweet these things and not just a Twitter thing and then think, oh, done. Well, fine. It needs to be repeated. So I noticed for myself doing this presentation that it would be good to improve my media capture of this paper. And you can all help me. You can all help me by tweeting this presentation, tweeting the take-home messages, or tweeting the paper itself. And I'm very much looking forward to your tweets, and I will retweet, and I will do a lot of things. I will try to like them and retweet them, but do mention my real name, and I'll give you my real name. This is my email, and that's my Twitter handle. So I would like to thank you for your attention for this presentation, and I hope you enjoy the day. For me in Australia, it's night, so I will enjoy a nice glass of wine after the Q&A. Thank you so much for joining me.